Live now.
Okay, thank you. Good evening, folks. This is the Central District Health Board meeting for Tuesday, October 27th, 2020. It is 5:16 p.m. I thank you for your attendance and interest. I call the meeting to order and introduce myself as the presiding chair. I am Betty Ann Nettleton, representing Elmore County, along with Representative Megan Blanksma. And I will now do roll call for our 4 counties, starting with Valley County. Valley County?
Here, sorry.
Okay. Thank you, Elmore County?
Representative present.
Boise County? Ryan, are you on? Commissioner Sturm? I don't hear Commissioner Sturm. Okay, Ada County? Dr. Young?
Jane Young here.
Dr. Epperly?
Ted Epperly here.
Commissioner Laciondo?
Commissioner Laciondo here.
Okay, thank you, folks. Okay, proceeding on with our agenda item. First on the agenda is the information item that the Board of Health will begin rotating the location of our future meetings for all Tuesday meetings between the 4 counties in our district served by CDH to ensure that members of our community have equal opportunity to attend and participate meetings in person. The meeting schedule will be updated to reflect this plan. So proceeding on under changes to the agenda, Russ?
Yes, Madam Chair, there is one change to the agenda. We need to add an action item, and that will need to be done through a motion and vote by the board to change the date and the location of the next meeting. And at that point in time, we'll have the full schedule worked out for the rotation. But if we're going to move the location based on how it's on the schedule right now, we do need a vote on that. The next meeting date is Tuesday, November 3rd, which is Election Day, followed by Tuesday, November 10th. So the board needs to decide the location, and we've been talking about Elmore County, and also whether or not you want to have the meeting on November 3rd or the next meeting on November 10th.
Okay, thank you, Russ. Then moving on to new business, let's make that our first item, since we were just discussing that. We'll be calling for a motion to approve the date of our next meeting and the location to be determined. So, is there
Madam Chair?
Yes.
This Russ, you need to
Yes.
vote on the updated agenda before we go on to that agenda item.
Oh, okay. All right. Well, I will ask for a motion to do that. Thank you.
Madam Chair.
Yes.
Go ahead.
I make a motion that we amend the agenda to include meeting times and locations.
Okay.
Second.
You. Thank you, El. Thank you, Diana. Is there any discussion before I call for a vote? Okay.
Madam Chair, this is Elt again.
Yes, El.
I guess you could go ahead and, well, no, this is discussion on the motion. So, Russ, one quick question to you. Do you have a lot of folks there right now that wanting into the facility? Is it a problem like it was last week?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
No, it's not. I'm at last count, I think we have about 12 to 15 people, and they're outside of the facility. We just have one news station who chose to come into the room. So
my concern is that I don't know if we need to move the meeting place. I think we have to create a reputation for our security system and our facility that we're not going to tolerate unmasked folks coming into the facility. I'm kind of wavering right now. I almost feel like we need to stay where we are and keep right on going to let people know they can't push us around. That's just my feeling.
Okay, thank you, Elt. Any more discussion?
Madam Chair, this is Representative Blanksma.
Yes, Megan, go ahead.
Thank you, Madam Chair. I appreciate the idea of moving meetings, and if we have to not be in the facility that we have here, then I am absolutely for moving them around the counties. I think just leaving them in a single county courthouse is untenable as far as I'm concerned. That being said, I agree with ELT 100%. If we can just maintain some normalness and some consistency with where the meetings are held, I think that's super helpful. And like Russ was talking here, and we just had 2 more people come into the meeting. There's 3. They're all masked. And I would like to have some consistency, if at all possible, rather than trying to move them around. That would just be my comment in support of what ELT is having to say.
Okay, thank you, Megan.
Madam Chair,
Who's speaking, please?
this is Diana.
Yes, Diana,
So just
go ahead.
a point of order, do we need to actually vote on the motion to amend the agenda and then we can discuss all of this?
Good point.
Yeah, good point. So let's go ahead and call for a vote on to amend
Madam
the agenda.
Chair, just as
Yes,
an answer to the point of order, the amendment of the agenda is a debatable motion, unlike a lot of others. So debate within that motion is not unacceptable.
Oh, okay. Okay, thank you. Any further points to be made before I go ahead then and call for a vote by county? Hearing none.
Madam Chair, this is Jane.
Yes, Jane, go ahead.
I just had a quick question, and that was if we did move it to different locations, how would we handle the open meeting requirements of posting and et cetera?
Russ, you want to address that?
Madam Chair. So the posting requirements would have to be, it would have to be noticed at the location. We would also notice it at our 3 facilities like we always do, as well as on our website. So the thing that would be added is there would have to be a posting at the location. So if, for example, Elmore County Courthouse or the law enforcement building were selected, then that would need a notice on that facility.
Okay, thank you, Russ. Any more discussion?
Madam Chair,
Hearing
this
none
is
on
Ted. Madam Chair, this
Yes,
is Ted.
go ahead.
If you could just clarify what it is we're voting on now.
We are voting on amending, this is a motion to amend the agenda to include the change to the agenda.
Okay, it's just the change to the agenda, not location, not date.
No.
Okay, thank you.
Okay. Okay, Valley County,
Commissioner Hasbrook, aye.
Elmore County,
Representative Blanksma, aye.
Boise County. I don't think Ryan is on. Ada County, Dr. Young,
Jane Young, aye.
Dr. Epperly,
Ted Epperly, aye.
Commissioner Laciando.
Commissioner Laciando, aye.
Okay, thank you, folks. That motion passes unanimously for that change to amend the agenda. Okay, then proceeding on under new business, the floor is open for discussion on moving or keeping our meetings at the present location. Feel free to weigh in, folks.
Madam Chair, if I may, this is Diana.
Yes, Diana, go ahead.
I just would really like to hear from Russ about what he feels is best from an operational perspective. We're not there every day. And I just feel like I'd like to hear what his proposed solution is.
Russ, would you reply, please?
Sure, Madam Chair. So what we've had going on is it's kind of on and off as far as the number of people who show up and protest starting back in July. So there's a lot of work that goes into preparing for this event. And like today, Boise Police Department has several staff here in preparation for a repeat of what we had last Tuesday. So it didn't happen this week, but it did happen 2 consecutive Tuesdays. So it's concerning to me for a couple of reasons. Number one, it takes a lot of staff time and resources to prepare. And secondly is, Central District Health Department has, I think, a really awesome mission of promoting and protecting the health of our communities. And with that, we want to be a welcoming environment, and to have the news coverage that we've had would suggest otherwise, as well as it's a significant disruption to our business operations. 2 Tuesdays ago, we had people enter not the conference room area, but where folks come in for food establishment permits and septic permits, and they were in there before 5 p.m., clearly disrupting the business, videoing and hollering. And there was, it would not be an environment I would want to go in to receive public health services. Plus, the basic fact is that if you live in Valley County and you want to attend the meeting in person, it's a 2-hour plus drive, and we're heading into winter. So make it even more difficult. And the same with Boise County, and to some extent for Elmore County. It's not a simple drive, although we do have board members like Representative Blanksma, who does make the drive to be here in person. So that's kind of the long and the short of it. I would expect we'd have fluctuations in the public interest depending on what's on the agenda and what their interest might be outside of just attending the meeting. So my recommendation is that we move the meeting to alternative locations, have each of our counties represented, so there's the ability for the public to have access, and that our primary functions can carry on without disruption.
Okay, thank you, Russ. Any further discussion?
Madam Chair, this is Jane.
Yes, Jane, go ahead.
Would our staff go there to help, or how would the streaming and the rest of that happen?
Russ?
Madam Chair, so Dr. Young, we're going to have to work through those details. So first would be to identify the location, which I know Chairman Betty Ann is working on right now in Elmore County, at least looking at some options. And what we would need to do, we don't have to stream it live from that location. We would definitely still be able to stream it through our YouTube channel. So at the location, it could be streamed like we do here at Armstrong, or it could be audio only for those who are attending, that they would be able to hear the meeting. So we feel like logistically it would be doable. We would just have to have either myself or one board member present at the posted location, much like we're doing today here in Ada County. So we can provide support. I just don't think we wouldn't need to have a lot of staff on site to make that happen. We'll work that out ahead of time.
Madam Chair,
Does that answer your question, Jane?
Yes, thank you.
Okay, thank you. El, did I hear you speak up?
yes, Madam Chair, thank you.
Yes.
Couple of things, Russ, to think about. In our situation in Valley County, we close down shop at 5 and our security and everybody goes home. So in order to do it at Valley County, we'd have to do it during the afternoon or daytime sometime. The second point I want to make is, can we adjust our hours of this meeting, say at 5:30 or 6 o'clock, so that we don't have staff in the facility and people coming in for services where we're pretty much empty out except for you and maybe security. I just feel like in my heart, if we start moving this around to different counties, we might stir up more trouble than what we're having there. Does that make sense?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yeah, we actually have people in our facility till well into the evening just because of the COVID response. So it would be an option though for, what you're talking about is the public accessible services generally end at 5 o'clock. We do have some clinic services that run later than that. Again, if we would adjust clinic services based on this board meeting, it would limit access potentially for that specific day of the week. But again, it's not something we would not be able to do if that's what the board chooses.
Madam Chair, this is Megan.
Yes. Yes, Megan, go ahead.
I completely agree with Elt. I'm concerned about people thinking that we're trying to hide the ball, and that's not at all what we're doing. And when we're moving meetings during the height of other people's concerns, then I worry about what that says. I'm not opposed to going county to county for meetings. I actually think that would be somewhat of an improvement long term about making sure that folks from individual counties get involved with what's going on Central District Health. I know that's been an ongoing discussion that we've had, Valley County, Boise County, making sure that our counties are equally served by Central District Health and that it doesn't continue to be so Ada-centric. But at this point, I'm looking around and these people want information. And I think that as long as people are just wanting to come in, get information and be a part of the process, I don't see a reason to move them yet. I think that as long as we can get folks that, and that's the crazy thing, is prior to the mandate that we put in place, which I understand, folks were concerned for staff. I get that. And it's really not fair to put staff through some of these things. But prior to putting in the mandate, most folks that were coming into the meetings were just sitting, listening, wanting information. And that's really our job, is just to get the information out. And so I don't know that I'm reluctant to move them around to the different counties, because I actually think that would be fairly productive. And it would be nice to have one in Elmore County where people can chime in on what their opinions are. But I do agree with Elt in that consistency is a much better pattern when we're talking about some of the quote unquote states of emergency that we're trying to get through. When we're looking at the conditions that we're trying to respond to, consistency is always a better path forward if we can provide that for folks that are attending the meetings. So I think if we can stay status quo as long as possible, then I absolutely would prefer that.
Madam Chair, this is Ted Epperly.
Yes, Ted, go ahead.
Yeah, I'd like to ask Russ a question, and then I'd like to follow up after his response. Russ, have you been approached by CDH staff with concerns about their welfare by having the meetings at the Central District Health building?
Madam Chair?
Yes, Russ, go ahead.
Yes, I have, Dr. Epperly.
Okay. Then what I'd like for us to consider, since we're in a pandemic, most of this meeting is virtual anyway. We, for the most part, don't have a lot of people trying to come in person. Most of it is virtual. I would be in favor of moving the meetings around so that we can make sure that they're in all 4 counties, since we've heard it stated that at least one of our board members is not happy with the Ada-centric system. And we know that Central District Health people are concerned about their welfare. It's unfair to keep it at this location if it's going to be disruptive to the business affairs of Central District Health and people have concerns. So I'm willing to make a motion that we do set up a rotating system, the logistics of which can be worked out. This is a virtual meeting, probably at 95% plus for anybody that's interested. We can work out the logistics from place to place, and we do that. So that would be my motion. I'll save discussion for a date, but the motion is to set up a rotating system.
Okay, the board has heard the motion. Is there a second?
I'll second that.
Okay, thank you, Diana. The motion has been made and seconded. Is there any further discussion? Hearing none, I will call for a vote, starting with, I'm sorry, go ahead, Megan.
Thank you, I appreciate that. And this is just to argue against the motion. I think that we should give this time. I think that we can provide separate entrances for folks that want to attend the meetings versus folks that want to have clinic services. I think we need to try our best to work within our current parameters. I think there are also legitimate concerns about the capacities in the outlying counties. We don't have the same sort of broadband access that is available in Ada County to do the full WebEx meeting. Instead, it tends to be all audio. Anybody who's attended these meetings knows that when the chairman or I are in Elmore County, we have to call in via audio because we don't have the video capabilities. We don't have the broadband to maintain a WebEx meeting. So I can't support the motion because I think that the more that we can maintain and the better the systems we can create for Central District, if it's already separate entrances for the meeting room versus the clinics. I think that we're better to maintain consistency. And again, I would go back to my original point. It's not that I disagree with having meetings in all of the counties. I think probably in the past we should have been better about that. But at this point, I think that consistency is key in making sure that with all of the really large decisions that the group is making, that people understand exactly where they're supposed to be at any given time to provide input. I think that's important.
Madam Chair, this is
Madam
Russ.
Chair, this is Diana.
Russ, I think you were first. Go ahead, Russ.
I just wanted to let you know that Commissioner Sturm has joined the meeting. Thank you.
Oh, okay, thank you. Welcome, Ryan.
Thank you.
Diana, you were speaking up.
Yeah, so, we're in sort of this rock and a hard place situation. Obviously, it's very unacceptable to me to have staff who don't feel safe going to work when they're in a, they didn't expect this. Certainly working at Central District Health, this is not what they signed up for. And I think maybe even more concerning than that, I know Russ has heard, I know Jane has heard, patients who are concerned about coming for services and sort of that reputation, and that's maybe even more concerning. So, I had offered to just come to the courthouse, our courthouse, and we could offer that consistency. You can be here till whenever. I understand and empathize with the look and feel of that maybe not giving the best impression that we want to give as Central District Health. So I do feel like Russ has come up with a good compromise there. But if the other counties are unable to host, then my offer stands to come on down to the courthouse where we have a much bigger space for holding a large meeting if people want to come in. And, we do this every day here at the courthouse from a security perspective.
So, Betty Ann.
Yes, Ryan.
I'm getting the gist. I get the gist of what we're discussing here, and I was gonna, on the same lines as Representative Blanksma was stating, Horseshoe Bend, and Boise County in general, doesn't have the capabilities. Both on the security standpoint and also from a meeting space standpoint, to be able to support any kind of meeting. We're already understaffed as far as deputies go. We have no city police departments except for Idaho City, and it's a one-man police department. We just don't have the ability to provide the protection or even the internet services, the telecommunication services, anything that would be, that would be able to support a meeting, especially of this size. And as much as I would love to be able to bring that meeting to Boise County, I think that there'd be a lot of people that'd be interested in it. We just don't have the resources to support it. I do like the idea of the courthouse. I don't like the idea that folks are coming to work and coming for services and feeling like they are in a bad spot, like they are in danger, or that they are at risk of any type of issue, retaliation or otherwise. And so I hate that that's going on, and so I think anything that we can do to mitigate that feeling is going to be a positive thing.
Okay.
Madam Chair,
you,
this is
Ryan.
El.
Yes, El.
you know, there's a real simple solution to all this, and we just have our meetings later in the evening when the staff and the offices are closed. I don't understand why that's so difficult to do. I realize, Russ, you got to work late, and we have to work late too. But like Ryan has stated, and Megan has stated that, and I think we're okay in Valley County as far as broadband speed. But I can guarantee you that we will have protesters show up for this, and I think we're just going to go around and open up a whole bunch of wounds in every county of these similar kind of thinking folks. I can just see the headline if we move this meeting somewhere else. I don't think it's good PR.
Madam Chair, this is Ted Epperly.
Yes, Ted, go ahead.
Then we have, I think, a pretty clear solution in front of us once we dispatch with the motion in front of us. And that is that we have one single location here in Ada County at the county courthouse. That would be the win-win-win in regards to making sure we had broadband, making sure we had safety, making sure that we could do this, making sure the public could attend. So the path to that, if we decide to do that, would be first to vote on the motion that's on the table and has been seconded. That would be a no vote. And then we need to propose a second vote after. If we can't host this in other counties, it makes it really clear. Then the choice is either do it at Central District Health or do it at the courthouse. Russ has made it really clear why we shouldn't do it at Central District Health. And else, to the point about doing it later, Russ's point is that there are many staff that work there until 9 at night on tracking and tracing and other public health related things. They feel unsafe. So that would be the path forward so that we can try to resolve this issue.
Madam Chairman, for a substitute motion.
Yes, Megan, go ahead.
So my substitute motion would be to conduct the meetings after clinic hours, which, and Russ, if you'd clarify, clinic hours are over and the patients are gone by 8 o'clock. Is that correct?
Madam Chair, Representative Blanksmith, that's correct.
So that'd be my substitute motion, which means we can continue in our same facility, but it would be after staff was available.
Okay.
Madam Chair, this is Commissioner Sturm. I'll second that.
We need to act on the motion that was on the floor first, I do believe.
Actually, point of order, Madam Chair, you vote on the substitute motion before you vote on the original motion. And if the substitute motion passes, then the original motion fails.
Oh, okay. Thank you, Megan. I appreciate that clarification. So,
Madam Chair, this is Ted Epperly. I'd like to ask a question.
yes, go ahead, Ted.
So Russ, you've heard the substitute motion. What are your thoughts about the after 8 scenario?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
I think that would be a better option. We do still have staff on site here. Like I said, doing disease investigation and contact tracing, so they have to leave the facility while, again, if folks were just showing up to listen to the meeting, that's a different deal than what we've experienced several different times since the July timeframe. So that's my primary concern, is Central District Health being in the media, for example, with people getting arrested for trespassing. Our staff have had protesters standing outside videoing their cars and license plates as they were leaving the facility. That has happened. So, you know, we'll make whatever work, whatever the board decides on this. But, you know, I think an alternative location where you have stable and consistent security would be the preferred option. This takes a ton of work, a ton of coordination with Boise Police Department, their resources. We have 4 security staff here today. And again, they're here before the start of the meeting. They're here following the meeting to make sure staff get out of the facility safely. So again, if it were just a normal board meeting where we have a handful of people show up, that's a different scenario than what we've been experiencing. And I would expect, even though it's relatively quiet today, that's going to change.
Okay,
Madam
thank you,
Chair,
Russ.
this is Jane.
Yes, Jane, go ahead.
I'm interested from the board members to find out how would you explain to the staff our concern about their safety and yet wanting to keep it at the same building?
Russ?
So I guess that question is, how would we explain to staff that we want to keep them safe, but we continue to have it at the same building?
Correct. I was asking the other board members. Sorry.
Oh, I'm sorry, Jane.
Madam Chair,
Yes, Megan, go ahead.
as the maker of the motion, I feel like I should say something in that I think that it's important to remember that we all are looking out for the welfare of staff. We're all looking out for the welfare of our families. We're all looking out for the welfare of our friends. But we also, this is public health. This is taxpayer dollars. And people do have a right to participate in meetings. And sometimes that's uncomfortable. And sometimes we don't like it. And sometimes we don't appreciate the way that people go about it. And I get that. But I think that we just do best practices. The folks that are interested in these meetings aren't interested in harassing staff. That's not what they're here for. They're here to listen to what we have to say and to participate in the meetings to the best of their ability. So I guess that's how I would explain it to staff, of we're moving it out of hours so that they would have limited contact with folks that may not have their best interests at heart. But in the end, we actually have to have a conversation about what it means to be public health.
Okay, thank you, Megan. Question for Russ and Megan. On this motion, are we going to need a separate motion for the date of our next meeting?
No, because you already set those.
Okay, all right. Okay, we will go ahead if there's no further.
Isn't it the set?
Madam Chair, the meeting is set for November 3rd. I just pointed out that that's election day, so that's just something for the board to consider if you want to go ahead and have it on that day or wait till the 10th for the next meeting.
Madam Chair, I believe Ada County Elections is using Central District Health as a polling location on November 3rd. And the polls open till 8.
Madam Chair?
Yes, go ahead, Megan.
So you could have a separate motion. So the substitute motion is to maintain at Central District Health, but run the meetings at 8 o'clock after staff is left. And then you could entertain a separate motion to, instead of having it on the polling date, which is the 3rd, to have it on the 4th. So we could do an additional motion that direction.
Okay, all right. Okay.
Madam Chair, this is Ted.
Yes, Ted, go ahead.
As opposed to doing it on the 4th with a second motion, the 10th would probably be a better day, just Tuesday, 1 week later, and miss the 3rd. So once we take care of the substitute motion, let's return to the date, because I think we need more discussion around the 3rd, the 4th, or the 10th.
Okay, thank you, Ted. Any further input?
Madam Chair, this is El.
El, go ahead.
I would just like to remind the chair that a tie vote is an automatic no.
Yes. Let's go ahead then and take vote by the county on the substitute motion, starting with Valley County.
Commissioner Hasbrook, aye.
Elmore County.
Representative Blake? Aye.
Boise County.
Commissioner Sturm, aye.
Ada County. Dr. Young.
Jane Young, aye.
Dr. Epperly.
Ted Epperly, no.
Commissioner Laxiondo.
Commissioner Lachiondo, no.
Okay. Thank you, folks. The motion does substitute motion does pass. Russ, do you want to shall we go ahead at this point and discuss the meeting for the, but we do have the option to cancel the meetings any otherwise noted as on the headlines of all of our agendas. So how do you want to handle that, Russ?
Madam Chair, if the board has a decision at this point for the November 3rd meeting, I'd like to get that taken care of so we can get the meeting plans put in place and the meeting cancellation or change posted. Otherwise, we can wait and decide sometime up until the afternoon of the 3rd.
Okay.
Madam Chair, this is Ted Epperly. I'd like to make a motion.
Go ahead, Ted.
I'd like to make a motion that we cancel November 3rd's meeting and move it 1 week later to Tuesday, November 10th.
Madam Chair, this is Jane.
Yes, Jane.
Second.
Second. The motion has been made and seconded to have our next meeting on November 10th. Is there any further discussion before I call for a vote?
Madam Chair, this is El.
Else? Go ahead.
Sorry, guys, but I can't make it on the 10th. I have a meeting with McCall City Council at 5:30 that night over the land swap from the State Department of Lands around McCall Lake. But you don't need me.
Who's speaking, please?
This is Megan. Madam Chair, question for El.
Oh, okay. Yes, Megan, go ahead.
So El, you don't think you'll be free by 8 o'clock? Since we moved the time?
No, I doubt it. There's a big controversy on the land swap. I don't know if you guys have heard about it, and we're meeting with the city council to kind of strategize and come up with a plan to do something different there. And it starts, I believe, at 5:30, and I don't know how late it's going to go. And then I got to drive home, which is 45 minutes.
And Madam Chair, I'm going to be out of town as well on November 10th. I may be able to call in, but I'm not sure yet. But
thank you. Any further discussion?
Madam Chair, this is Megan. A question for Russ, please.
I'm sorry, Megan, I couldn't hear you.
Sorry, I have a question for Russ, please.
Oh, yes, go ahead, Megan.
So Russ, do you anticipate any sort of changes in orders that would happen on the 3rd that would necessitate us to have a meeting on the 4th or 5th?
Madam Chair, this is Russ.
Russ, go ahead.
Actually, Representative Blanksman, I think there could be changes to the order. We're going to hear from the hospital systems here shortly after Kim presents, and I would say their situation is deteriorating quickly. As Kim will present, the numbers are rapidly rising, particularly in Elmore County as well as here in Ada County. So I think the potential's there that could be something that the board's going to need to consider sooner than the 10th.
Would you guys be willing to meet on the 4th and cancel the 10th?
Madam Chair, this is Ted.
Yes, Ted, go ahead.
Yeah, El, that would be fine with me on the 4th if that's easiest. Russ, how about, since with the prior motion, it would be after 8 o'clock, Wednesday, any issues, Russ, at all with it being in your facility on the 4th?
Madam Chair, this is Russ. Dr. Epperly,
Yes,
no
Ted.
issues.
Okay, thank you.
Madam Chair, point of
Yes,
order.
Megan, yes.
Yeah, if Dr. Epperly wants to just change it to the 4th, he can amend his motion and ask his second to change it, and we can move on without any motion.
Yes, Ted, would you like to amend that motion to accommodate
Perhaps.
that date?
Thank you, Betty Ann. Perhaps before I do so, anybody have any issues with the 4th? Please speak now if you do.
This is Betty Ann, I'm good.
Okay. Hearing nobody's response, I would make the motion to change the motion then, and we'll move the time from the 10th, Tuesday the 10th, to Wednesday the 4th of November, 8 o'clock, Central District Health.
Okay, thank you. Is there a second to the motion?
This is Jane again, second.
Okay, thank you, Jane. The motion has been made and seconded. Is there any further discussion before calling for a vote?
Madam Chair, I'm not sure, sorry, this is Diana. I'm not sure if I'll be available or not. I will be on a plane potentially, but I don't think that should hold you back if we have stuff to do.
Okay, thank you. Valley County.
I have no issues. That would work great for me.
Okay. Elmore County.
Elmore County votes aye.
Okay. Boise County. Ryan.
Commissioner Sturm, aye.
Ada County. Dr. Young.
Jane Young, aye.
Dr. Epperly.
Ted Epperly, aye.
Commissioner Laciando.
Commissioner Laciando, aye.
Okay, thank you, folks. So our next meeting is set for November 10th at 8 o'clock at Central District Health. Okay.
Betty Ann, just a correction. It's November 4th.
Right.
Betty Ann. Wednesday.
What did I
Wednesday,
say?
November 10th.
Okay,
Yeah.
I'm sorry. I stand
That's
corrected,
okay.
November 4th. Thank you.
No problem.
All right. Proceeding on with our under new business, we need to approve a vote to a motion to approve our meetings from our October 16th board meeting. Are there any additions or corrections to those minutes? Hearing none, I will ask for a motion for approval.
I'll second Jane's motion.
Okay, I got that out. Who seconded it?
I seconded Jane's motion.
Yep, I was just
okay.
about to say that. How did you know?
All right. Thank you. Thank you. Okay, any discussion before I ask for a vote by county on approving the October 16th minutes? Hearing none, I will call for a vote from Valley County.
Commissioner Hasbrook, aye.
Elmore County.
Representative Blanksma, aye.
Boise County.
Commissioner Sturm, aye.
Ada County. Dr. Young.
Jane Young, aye.
Dr. Epperly.
Ted Epperly, aye.
Commissioner Laciando.
Commissioner Laciando, aye.
Okay, thank you, folks. The minutes for the October 16th meeting stand approved. And we need also to approve our October 20th board meeting minutes. And are there any corrections or additions to those minutes before I call for a motion? Okay, do I have a motion for approval on those minutes?
Madam Chair, this is Jane again. I move that we approve the minutes as written for October 20th board meeting.
Thank you, Jane. Do I have a second?
Madam Chair, Commissioner Sturm, I'll second.
Thank you, Ryan. Okay, hearing no further discussion on approval or additions to those minutes, I will call for a vote by county, starting with Valley County.
Commissioner Hasbrook, aye.
Elmore County.
Representative Blanksma, aye.
Boise County.
Commissioner Sturm, aye.
Ada County. Dr. Young.
Jane Young, aye.
Dr. Epperly.
Ted Epperly, aye.
Commissioner Laciando.
Commissioner Laciando, aye.
Okay, thank you. Those minutes for our October meeting stand approved. Okay, next on our agenda, we have a review of the COVID-19 metrics for criteria for determining quarantine and restriction orders for Ada County by Kimberly Link, Communicable Disease Control Manager. Kim, the floor is yours.
Thank you, Madam Chair. So the first slide that we're starting with is the one titled Central District Health Ada County Criteria Summary. Before I jump into the broad overview of what we've seen over the past couple weeks, I will just say that last week was a really rough one, I think, for our health district as a whole. We ended up having over 1,200 cases reported across our health district, with the majority of those coming out of Ada County. We haven't seen these numbers since back in July and August. We're definitely back into seeing widespread community transmission, and the impacts of that are definitely being seen, and as you'll hear, throughout the healthcare sector and other areas of our communities. So looking at the the broad overview, when we looked at the hospital gating criteria, ICU admissions over the past 2 weeks remained reasonably flat for our Ada County residents, not seeing large increases there, which is a very good place to be. However, our non-ICU admissions did trend upward. And as Russ had mentioned, we saw a significant increase in the number of cases that were reported. As I mentioned, we were over 1,000 for Ada County, and that put our trend line starkly upward for our 2-week trend. It was a 66% increase in the number of cases as reported, as compared to what was reported the week prior. In addition, we saw that last week, 6 out of 7 days exceeded 100 cases per day being reported among Ada County residents, and we had 2 days that were over 200 cases being reported. So definitely stark increases in the number of cases that came out of last week. The clusters that we are continuing to monitor include the Boise State University faculty, staff, and students, outbreak going on at the Ada County Jail, outbreak at the different IDOC facilities down in CUNA, and our long-term care facilities. So we went from 27 facilities with active outbreaks having cases within the past 28 days. Last week, we're up to 29 facilities now this week, and seeing further cases among staff and residents of long-term care facilities. And if you could go to the next slide, please. So looking, this is the slide titled Hospital Criteria. And looking at our hospital criteria in more detail, the bar graph and the line graph show the non-ICU admissions among Ada County residents. And as I mentioned, this is trending upward quite significantly. The bar graph shows over the past 4 weeks, and the line graph that includes the trend line is over the past 2 weeks. So you can see we've gone from single-digit admissions back in September to now being, we had 1 day where we hit 30 people, Ada County residents, being hospitalized for COVID. If you could go down to the next set of graphs. So this middle set is the Ada County residents who were in ICU care for COVID. And as you can see, over the past month, really, and especially over the past 2 weeks, we haven't seen large-scale increases in our ICU admissions, which is a nice thing to see in all of this going on. As we look at the 2 bottom sets of graphs, these are looking at the hospital census in Ada County hospitals. So not looking at Ada County residents in particular, but looking at the number of patients who are admitted in Ada County hospitals as a whole as a result of COVID. And again, the graph on the left showing non-ICU admissions, we're seeing that increase over the past couple of weeks, and similar trend to what we see with Ada County for the ICU admissions being reasonably flat over the past couple of weeks. If you could go to the next page.
Kim, can I clarify something, Madam Chair? Could you go back, please?
I'm really getting a lot of feedback. Is that you, Megan?
No, this is Diana. You all hear me?
No, I can't. I'm just getting static.
Okay. I'll log out and log back in. Go ahead.
Kim, is that you speaking? I can't even tell who's talking.
Madam Chair, that was Commissioner Lasciando.
Oh, okay. All right.
She said she's going to log out and log back in.
Okay, thank you. Go ahead, Kim.
Okay. So the next slide that we're on is the one titled Disease Criteria. And the top graph, you'll see this is Ada County residents as a whole, confirmed and probable cases by day of report, looking at the past 4 weeks on the left-hand side, and then on the right-hand side, we have the 2-week with trend. And as you can see, as I had noted, multiple days of greater than 100 cases. You can see the couple of 200 case days that we had and that upward trend. If you can move to the next set of slides, or excuse me, to the next set of graphs, so move down the page. Perfect. So this next set looks at Ada County, but it excludes the inmates in the IDOC facilities in our region. And what you can see here is, again, we're still seeing an upward trend. And what this is indicating is that the majority of the cases that we're seeing right now are coming out of the community, that these are, this is not prison outbreaks. There are, some cases that are coming out of there still consistently at this point, but this is illness that is within our community, and that's what's driving that wide-scale community transmission. And then the bar graph at the bottom, again, you can see as you look to the right there, that date of October 18th, 1,152 cases as compared to 696 the week prior. So a huge increase based compared to what we saw last week, and definitely an increase that's concerning. Next slide. This is the slide that's titled Ada County Case Rate and Emergency Department Syndromic Surveillance Information. So the top graph includes the Ada County 2-week average daily case rate. This is what we use for determination of the school categories. And you can see with that increase of cases, that drove our case rate up further. And our most recent is we are sitting at 27.41, which is solidly in that what we're calling the red category. I know right now there are some questions. State Board of Education has moved to a 4-tier system. Right now we are still using the 3-tier system for the schools. So we are in Ada County Category 3 red. And the middle sets of graphs, this is our emergency department visits for people presenting with fever, cough, shortness of breath. We did have one day last week where the number was significantly higher than what we've been seeing. However, the overall trend for that has been reasonably flat. And if you could scroll down just to the bottom, and this last graph is the ED visits by week. And so you can see we've been really over a period of a couple of months, we've been in the range of about 40 to 50 emergency department visits per week with that COVID-like illness. And so that's the overview of the Ada County information. I did not include it in this slide set, but Russ did bring up the increases that we're seeing are not just affecting Ada County. We, over the past month or so, have been seeing increases in Elmore County, and this past week, Elmore County had the largest number of cases in 1 week than we've seen so far in this pandemic. There were 61 cases being reported. Of course, as we're comparing to Ada County, a much different scope and scale, but putting it into perspective, Elmore County does have a much smaller population, and looking at it as far as the case rate goes, 61 cases in a single week equates out to a case rate of about 31 cases per 100,000. So the number of cases that we're seeing in Elmore County, again, even though sheer numbers are much different than Ada County, they are still definitely concerning. We are seeing impacts in terms of hospitalizations as well. And I think that's the end of my report. I'm happy to take questions.
Madam Chair, can you hear me now?
Yes, I can hear you loud and clear, Diana. Thank you.
Okay. Sometimes I got to log out and back in.
Kim, thank you. Thank you.
So, Kim, I think this is going to be important as we get into the report from the hospital systems, because we're really getting into more of a regional issue at this point. Would you be able to share, obviously this is not good for Ada County, but as I look at the numbers statewide, our case rate is still one of the lower case rates statewide. Can you share where we're sitting there and where we're sitting from a positivity rate by health district compared to other health districts?
Madam Chair, this is Kim.
Yes, Kim, go ahead.
Sure, Commissioner Laciando. I don't have the data right in front of me, but you're correct that the increases that we're seeing in Ada County are falling in step with what we're seeing statewide. In terms of percent positivity, we've been consistently over the past couple of weeks in the 6 to 7% positivity range. Ideally, we'd like to be below 5%, but 6 to 7% is an okay place to be. What that tells us is that our testing capacity really is keeping up with the level of illness in our community. So the numbers that we're presenting and that we're seeing in terms of the people who are identified as testing positive for COVID, we're getting a good representation of the level of illness that's in the community. Unfortunately, that's not the same statewide. I know that the state's coronavirus website, they include that information that they're updating on a weekly basis, and we're seeing in some of the other health districts that their percent positivity is in the teens, if not in the 20s. So whatever numbers are being reported out from other districts, which I know those numbers are equally alarming with cases over 100 a day, in many areas on a routine basis, the level of illness within those communities is most likely markedly higher than that.
Betty Ann, this is Ted Epperling.
Yes, Ted, go ahead.
Yeah, just a comment to the rest of the board and also to the public that might be watching. As we've seen these cases go up fairly precipitously over the last couple weeks, again, COVID-19 kind of runs in 1 to 2 week cycles. So what we'll see is case numbers go up, and then 1 to 2 weeks later, we'll see hospital numbers go up. And then 1 to 2 weeks later, we'll see ICU admissions go up. And 1 to 2 weeks after that, we'll see deaths happen. We're kind of exactly in this as a third spike again. Cases are going up, 1,152 in Ada County over the last week. We're seeing the hospitalizations go up. Even though the ICU numbers are flat at this point, they'll go up. And I'm sure that both Dr. Souza and Dr. Nimerson will speak to this here shortly. But then we'll also see deaths go up. And that's the whole point of public health here, is what can we do at this point in time to start to make a difference in that number, to help start to flatten the curve, if you will, for this. So I know we'll talk a bit about that after the hospital reports, but I just want to remind everybody, we're on the cycle again. That is the cycle we'll see happen.
Chair, this is Zelt.
Yes, El, go ahead.
I'm not sure if I need to ask this to Kim or Dr. Epperly, but is there a feeling, because the ICU numbers aren't going up, although we're seeing more people in the hospital, is this virus getting weaker? And I don't know who wants to answer that.
Well, Elt, I'll certainly answer first, but Kim certainly can, and then both of our excellent chief medical officers can answer afterwards. No, Elt, I don't think it's necessarily saying that it's getting weaker. The transmissibility is, with some of the evolution of COVID-19, has made it more transmissible to others. I'm not so sure that the lethality of it has increased. But what we will start to see, because again, as it gets into the older population, which it does, it kind of finds and seeks the most vulnerable, if you will, we will see those numbers go up, not because the virus has changed as much as it is the exposure to the virus and its presence is increasing in the community.
Thank you.
Okay, thank you. Any further discussion or questions for Kim before we proceed on? Hearing none, we'll move on to a COVID-19 situational report from St. Luke's by Dr. Jim Souza, the Chief Medical Officer. Dr. Souza, are you there?
I am. Can you hear me okay?
Yes, we can. So the floor is yours.
Great. Thank you. I really appreciate the opportunity. I wanted to give an update on what we're seeing in our hospitals, what we've done to prepare, actions that we're preparing to take, and an update on our staff. We're experiencing a marked increase in disease activity across all of southern Idaho, and our hospital capacity for care is eroding around the state, and certainly in our part of the state. That is also a true fact. As everybody knows, I think, we serve a number of counties across southern Idaho. You're all probably aware of the increasing activity in all of these counties. I want to make a connection, though, about how we are all really interconnected in this effort. So, Jerome County is up to now 55 cases per day per 100,000. Twin Falls is up to a whopping 86. In the past week, Minidoka has been as high as 120. And you might ask, well, why do we care about that in Central District Health? And the reason is because Minidoka and the other rural counties around Twin Falls, they're the top of the funnel into Twin Falls and our facility there. And as that facility reaches its capacity, as I'll share in a moment, they move their patients west here to Ada and Canyon counties. So within our hospitals, our capacity for care is eroding, and frankly, the funnel is getting clogged. Only 3 weeks ago across our health system, we were running an inpatient COVID census in the 30s. 1 week ago, that was up to the 75 range, and today we were hovering at 90. We have 12 to 15 patients in critical care locations with COVID at this time, and we know, as Dr. Epperly says, this is going to increase. But, I also wanted to point out that these are superimposed upon our other ICU care. So our ICU capacity, we've been running at about 125% still of normal volumes. In addition, and I don't have a great explanation for this, there's plenty of theorizing about it, but we're seeing a year over year 25 to 30% increase in stroke and heart attack presentations. The thinking is that this is probably related to the disease's propensity for creating clots. It's well known to cause a hypercoagulable state. Regarding Elt's question about, is this becoming less virulent? The answer is no. I think our treatment algorithms are better, but what that's going to translate into is, I hope, more people surviving, but spending a significantly longer period of time in our intensive care units. So Magic Valley has been particularly challenging. I just want to, because I want to share a little bit about that, because I think it could foresage what we'll see here. I think we can still act to prevent that, but that's a 125 bed facility. It's a community hospital. They've been running a census for 3 weeks of 40 COVID patients, and in the past week it's been 50. Today, like half of their admissions were sick COVID patients. What have we done to respond there? Well, we've canceled certain elective or less time-sensitive surgeries, less time-sensitive cardiac procedures. We've intermittently adjusted our nursing staff ratios. Last Friday, we closed our pediatric unit in order to get some more adult beds, and with that comes the decision that we'll be moving sick children. We'll still admit babies there in our NICU, but sick children will move west to our Children's Hospital in Boise, and we'll be prepared to take those. In addition, we've had to divert patients west to our larger facilities here multiple times in the past week. Thus, the interconnection between everything happening in South Central Idaho and what's happening here in the Central District. You also may have heard the news out of Utah today that they're not able to accommodate any out-of-state transfers. So the point of that is that, as one of my colleagues, Dr. Josh Kern, said this week, there is no cavalry coming. We are it, and it's up to us and our communities to act to preserve our capacity for care. Of course, you guys, it's not just a matter of beds, right? You got to have healthy people to take care of the people in the beds. Today at St. Luke's, we have 108 people out sick with confirmed COVID, and almost 70 of those were clinical staff. The overwhelming majority of our COVID positive cases are acquired in the communities where our employees live. They're acquired in businesses without safe practices, or at public gatherings, or in smaller multifamily events in backyards. Now, we're not just standing by and waiting and, not taking action. I want to be really clear about that. We have hired more than 500 nurses since March. We still have 150 open positions right now. We're actively seeking travelers. So is most of the Intermountain West and the Midwest. So they're hard to come by. We've been preparing our inpatient facilities for a surge in activity. Last week, we came like this close to actually implementing the next phase of our surge and closing our cardiac observation unit and turning it into a new critical care unit. That, of course, would have meant here in Boise also pausing less time-sensitive cardiac care and vascular surgical care. We came so close that we actually assembled the equipment to make it happen. And then sort of at the last minute, frankly, we had some deaths and some discharges, and were able to make room, and we eked by. But with the community numbers hitting the astronomical kind of levels they have, we're no longer thinking that those plans are just in case. We really feel like they're just in time. We've reduced our elective surgical cases in MAGIC, as I've said. And so to be clear, we're prepared to progressively turn our facilities into COVID facilities. We just want everybody to know the heavy price that comes with that from delaying care that people need. Finally, I just want to close with how our people are doing. They're amazing. They're working hard. They're doing extra shifts, and they're fatigued. They're fatigued of the physical burden of this care. If you've never seen a critically ill COVID patient, it's eye-opening. Many of them are so sick that they're chemically paralyzed and can't move. We have to move them, attend to literally all of their needs. The physical burden obviously is high. In addition, the psychological burden on our staff is tough. They really care about people. The fact that in the name of safety and containment, we need to limit visitation is a hard message to convey. They're also fatigued of watching a disease process play out that we know really well as healthcare providers is so highly preventable. We're seeing way too much needless suffering and death. And a lot of this is preventable. Within our facilities, virus transmission is a very rare event, despite the fact that we have hundreds, and on some days even thousands of our people interacting directly with confirmed COVID-infected patients. And finally, they're fatigued of living in two worlds: the world they live in at work, where they employ good practices, they see good practices, they see containment, and then the world they encounter in the public square, where those behaviors just are too often not on display. So I'm going to conclude by just saying we're in a window of opportunity that is closing for us, but an action's required now. I want to publicly acknowledge and appreciate the action that the governor took and his call for responsibility. The message is really simple. We do not need to shut down large segments of our economy, and no one in healthcare who actually cares about health wants that. The prescription for us to achieve both a healthy economy and preserve our capacity for care is super simple. When you're with other people besides your own family, put a covering on your face and watch your space. That's it. That's what we have to do. I don't know if you all can take actions to support that, but with that sort of action, I think we can have a different end to our story than what's happening in Utah, for example, right now.
Madam Chair,
Yes, Megan, go ahead.
I would just ask unanimous consent that we move on to Dr. Nemmer's report so that then we save all of our questions for after both of the doctors have spoken.
Madam Chair, I actually have a specific question for St. Luke's.
Go ahead, Diana, make it brief, please.
Thank you. So, because you are playing in that regional space, coming over from Wood River Valley to Magic Valley to here, one of the questions that I have received lately that I know the answer to, but would like you to answer publicly because I'm getting it a lot, is, why don't you just not allow people from Twin Falls to come here? If we're preserving our Ada County capacity, why not just allow them? And, obviously I can make that moral argument that you've all taken the Hippocratic Oath. But I think it would be helpful for the public to understand that you also operate under EMTALA, and legally you cannot refuse patients. Could you explain that for the public?
Yeah, that's correct, Diana. We can't do that. That's federal law that would prohibit that. Moreover, we're part of a health system, so we, sort of take care of our own, and as facilities fill up, we need to take care of our own patients. But at the end of the day, we're all in this together. If St. Alphonsus finds themselves on divert, well, what if we don't have capacity? If we're on divert, what if St. Alphonsus doesn't have capacity? And, in Utah, right, they're starting to discuss crisis standards of care. If we let that happen, that will have been a failure in so many ways. But if we move to that point, the governor would not declare a crisis unless we had exhausted the opportunities to, for example, move patients from southern Idaho to northern Idaho if they had like one extra ICU bed. So I don't know if I answered your question, Diana, but we can't do it. We shouldn't do it. And our values also would guide us away from ever doing that. I'd turn it to Dr. Nemerson.
Thank you, Dr. Sousa. Dr. Nemerson, are you there? And the floor is yours, as I see Katie Quinn, your safety officer, is on also.
Yes. Well, good evening, and thank you for the opportunity to give you our experience at St. Alphonsus. I'll start by saying, first of all, I want to acknowledge the time and effort and multiple hours that you've each put in to partnering with us to try and work through this pandemic. We are all tired. We've all been losing countless hours of sleep to try and figure out how to do what's best for our communities, and I recognize that. I'm going to start with our people and tell you that we too are experiencing almost all the same things that St. Luke's is experiencing. Our people are acquiring the virus in the community. Acquisition within our facilities is almost zero. When it does occur, it's because two colleagues have come into contact with each other, usually eating lunch too close and not wearing masks. And so the phenomenon of transmissibility is very, very clear. It's by not face covering and not keeping distance. We are experiencing an increase in the number of people who are on quarantine. And I'll also put out there that because of what's now happening in the community in terms of the surge that you've all described, daycare centers and other support systems that are in place for our staff, and primarily women work in nursing, and those are the ones who are most heavily affected by COVID. Even when nobody is sick in their family, they can't get the support services like daycare that they need, and then they can't work for us. So we're seeing now a compounding of this COVID phenomenon where a significant number of our staff are getting sick and can't come to work, and a smaller number of our staff are unable to get the support services they need in the community and aren't able to come to work. We're stretched very, very thin. Our total COVID census is only around 10% of our total inpatient volume across the system. And as you know, we operate 4 acute care facilities. But that 10% on top of what Dr. Souza's already referenced, the regular medical and surgical care that we need to provide and what we call medically necessary time-sensitive care, which is more urgent. In order to deliver all of that, we're at the point where we're becoming compromised. And if I were to show you our growth rate, you can see the trajectory shows, based on our modeling, that within the next couple of weeks, we expect to be at about a 20% inpatient census, and that's the breaking point for us. That's the point at which we then have to discontinue. It's not even elective surgeries and care. It's more necessary, but not truly emergent or urgent care. And so we're looking at that, and we're planning for it actively and have been in a position to do so since the beginning of the pandemic. For incident command surge plans, our plan then is to, we've already started actually, begin to care for patients in areas that are not traditionally used for clinical care. We have them available, but they're spaces that we haven't need to use. And we're already moved a couple of patients into those spaces, and we're going to continue to do that expansion as the COVID volume continues to increase. At a certain point where it then becomes necessary to discontinue those medically necessary things, we will do that as well, and we will become a more and more full COVID system. The last thing that I want to reference is equipment and medication inventory, because Jim didn't highlight that. And we're actually in pretty good stead with that. The ventilators and the beds, which you heard about earlier in the pandemic, because of the nature of care having improved, we've learned more about how to take care of this virus, how to support patients without ventilators. As a result of that, we're in a pretty good position for what I call hardware. Medications, however, there are periodic shortages in a number of those medicines, and the supply chain has not improved in the past few months. And so we are concerned that as patients with these COVID-related medical needs come on board, that we're going to see issues around our overall medication supply that they need. The last thing that we also haven't touched on, and at least in this conversation, is access to those innovative cares that we think are helpful. There is not a cure for COVID. I really want to emphasize that. But there are treatments that are shown to be effective. Among them is a steroid called dexamethasone. We've got access to that across the valley. We also have access to a medication called remdesivir. I'm sure that others have heard about that. It is not a golden bullet, if you will, to kill this virus, but there are indications that suggest that it is helpful. And our inventory on that is good right now, but if the numbers really explode, then we're going to have an issue around getting access to enough remdesivir. Other therapies that we have, convalescent plasma, that is a blood product that is obtained through the American Red Cross. We have access to, it's actually a fairly cumbersome process for the Red Cross to obtain it and get it to us, and it's not used that commonly, but we have access to it. And then there are other therapies that are out there that are being tried, that are showing promise, and again, they're used in rare circumstance. But I think in the end, it's important to emphasize that, number one, the numbers are growing, and our systems are currently under stress, and within a matter of weeks, if this trend does not change, we will be more than under stress. We will be compromising. We will be making decisions that essentially discontinue or delay certain kinds of medical care and therapy. And then additionally, we don't all need to panic that this is going to happen tomorrow, but we need to really think very, very hard about what we each as individuals and as community leaders can do to change this trend so that we don't end up in the situation that Wisconsin is in, that Utah is in, that many other areas in this country are in, where they literally do not have access to adequate staff and facilities and other therapies. And I'm happy to answer any questions around this. I think the other thing to comment on, or the last thing that I'd like to comment on, is that the data also shows something else, which we really don't pay that much attention to. And that is, this is our third surge. We've had two previously, and in both cases, the situation has gotten better. The reason that the first surge didn't get so bad and improved dramatically was because of an aggressive shelter in place, which we are not advocating, but it demonstrates that physical distance makes a difference. The second surge that we experienced in July also got better, not back down to the previous baseline, mind you, so that's regrettable, but the fact is it did improve, and the reason we believe it improved is because of the messaging that we sent out, the encouragement and some limited mandates to wear masks and physical distancing, combined with the fact that we had the benefit of summer weather to keep people apart and to keep them outdoors where there's good ventilation. We don't have the benefit of that now. We're moving into the winter season where we have a, if you will, perfect storm to perpetuate the spread of COVID. People are going to have to be indoors. If they're connecting with others, they're going to be in spaces that are not well ventilated. They are going to have to make decisions about who they cohort with and who they don't cohort with. And it's important they don't cohort with any strangers, as Jim's already said. So all this combination of being indoors, poor ventilation in those spaces, people not wearing masks, people not physical distancing, and then the last thing which I've mentioned is, and other respiratory illnesses and winter illnesses that we're used to seeing, the common cold, influenza, other types of respiratory viruses, they set up the lungs for having more damage when COVID attacks. So we don't want this, and we really need to turn this trend around by doing the simple measures that we've already described so many times.
Madam Chair, this is Representative Blanksma.
Yes, Megan, go ahead.
Thank you. I have a question for both Dr. Souza and Dr. Nemmerly. I asked several months ago from Chris Roth, who's the administrator for the St. Luke system and a person I knew, as well as the legislative liaison at the Idaho Hospital Association, to provide us with some idea of what the surge plans look like. So how the dominoes fall. So if the cases come up to X, then Y happens. Needless to say, I never got any of those scenarios. I think there's a huge distrust on the numbers that are coming out of the hospitals. And I'm just asking that you can help me, that if you want to explain to people how these dominoes are falling, is there a way we can get some scenarios that we can share, to get some data that we can share, so it's not kind of an ethereal number of when the hospitals say it's bad, because that's the situation as far as with my constituents I live in that they're not necessarily trusting of the numbers and don't understand necessarily in hospital talk what that surge means. And I don't know if I'm being clear on my question, but that just providing scenarios so the public understands what that means when you have to start switching over beds from being hip and knee surgery to all of a sudden you've got an influx of COVID patients.
So our publicly reported, let me, one comment you made, Representative Blanksma, was sort of a certain number of cases at X leads to Y. That won't be the trigger point for us. It'll actually be the capacity for care, which will be the COVID patients plus the other time-sensitive patients, plus the healthy staff to care for them, plus supplies and equipment. And I'm glad Steve mentioned that because we are in a lot better shape there. If you look at the Utah example, what's happening right now, I mean, they've got this big facility that they're talking about for overflow and no one to staff it. So at the end of the day, it's all three of those together. And I do believe our publicly available dashboard, and Steve, I think Al's is putting this information out there too, captures those elements. To the degree that it doesn't, I'm interested in more conversation. Representative Blanksma, I will run this up our flagpole at St. Luke's. What about the statements of what I perceive as fact are questionable?
I think some of the pushback, I'm sorry, Chair, if you'd allow me to answer.
Go ahead, Megan.
I think that a lot of the pushback that I'm getting is just distrust of the numbers between what is perceived as an essential care versus what is like a hip or knee replacement, right? Just for an example. And I am not trying to cast doubt on the hospital. I'm not trying to advocate for one position or another. That is just some of the concern that's been brought to me. Now, granted, I'm from Elmore County. I actually think you and I have met before when I used to sit on the St. Luke's board. But, and I know that ours are coming into Boise. I'm just looking for some way to show as much transparency as we can to the public so they trust those numbers. So, because that's the pushback that I'm getting, is that instead of, and again, I'm not necessarily advocating for this position, but if you're asking where the questions are coming from, it's people who are concerned that there isn't really a surge. It's that the hospital wants to do their elective surgeries. And so I don't know, that was why I was asking for the scenarios of where do we get to the point where the surge becomes so heavy that there's no elective surgery available, and maybe even what that elective surgery means, because you've actually given a better definition than anybody I've heard thus far when you start talking about cardiac care. So I think I know there's definitely education needed there. If you want to convince the public that you're starting to hit your surge plans, we need to do a better job of educating. And that's why I'm saying if you want me to help you, I need you to help me. and that was something that I asked for months ago. And so I'm just curious if you have that sort of example that you can provide for other people that's just a very clear if then what.
Madam Chair.
Go ahead.
It's Commissioner Sturm. I'm going to help Megan out here a little bit with the information that she's looking for, because I get the same pushback, but being in the healthcare field myself, one of the things that I would actually, and I think people need to hear it, and it's not pleasant to hear, and it's not nice to hear, because it takes away humanity of the situation, right? But I think if both Dr. Nemerson and Dr. Souza could speak on, when it comes to crisis mode, exactly what that means when it comes, it's not knee replacements, it's not cardiac care, the minor cardiac care that doesn't happen. It's you come to the hospital with pneumonia and a potentially deadly disease, and they will not be able to provide care for you because they already have everything going to a COVID patient. So now they're going to have to send you home potentially, or send you somewhere else, or tell you there's nothing they could do for you. And no hospital system and no medical provider wants to be in that position. But what they're saying is that at some point they hit a number where that's just how it is. It's the same thing here in Boise County. If I get 2 ambulance calls at the same time, someone's not getting an ambulance. It's just life. It's just what it is. But unfortunately, I'm the one that has to make that decision who gets that ambulance. And that's the ultimate where I think, where Dr. Souza was going with his statement was that's where they're headed. They're headed in a direction where someone who needs life-saving care at some point is not going to get that care once they reach a certain breaking point within their capabilities. And it's not, someone's going to have to make that decision. And you correct me if I'm wrong, gentlemen.
No, you're right. And maybe in responding to Representative Blanksma's line of concern first about, I'm doing air quotes here, elective cases. Those clearly exist on a spectrum. I'm sure you'd hear the same from Dr. Nemerson. And you can describe that spectrum, right? You can say, well, on the really mild end, I mean, somebody with a hernia. Well, what's the big deal with waiting? Well, a certain percentage of those, if we wait too long, are going to come on with a bowel emergency, an emergency surgery. A total joint replacement, that's kind of not a big deal, right? Well, a certain percentage of them will suffer a fall and a head injury and end up at St. Al's at our trauma hospital needing an intervention because that got delayed. And I'm not going to share. I'm not going to overshare here, but I do know. I mean, I know the names of some individuals who, with the shutdown of, again, air quotes, elective care, some of that involves the cardiac spectrum as well, who aren't with us today because of delays in care that happened. So it exists on a spectrum. Regarding the topic of crisis standards of care, everybody knows what that means probably, but I'll just say it since the public is on here. Since the beginning of this pandemic, all the states, including Idaho, have been preparing for this eventuality. Early on, we thought that we were worried that it was a foregone conclusion that we couldn't stop this thing. And this was back before we understood as well as we do now how it spread. So the governor in the state of Idaho impaneled a pretty large-sized task force. All kinds of providers were involved in that. And they created our crisis standards of care framework. For those to be effective, a couple of things need to happen. The first thing is that the governor needs to declare that it's a crisis. And the second thing that happens is that the individual then healthcare systems need to actually stand up the triage teams that would implement the crisis standards. What crisis standards means is that if capacity was in such short supply that on presentation to the emergency department, people would be, a determination would be made whether or not they qualified, not for admission to the intensive care unit, but for a trial of admission to the intensive care unit that would last 96 hours. And at the end of that 96 hours, they would be reassessed with a severity of illness organ failure score. And decisions would be made at that point about continuing to allocate that resource to that individual human being or deallocating that resource. That is such a creepy future scenario. None of us wants to go there. And as when I alluded to it earlier, I feel like given what we know about the transmission and the pandemic at this point, if we go there, that'll be a failure on all of our parts. Because I don't think any states have had to implement that yet. This is our third surge, though, and it's looking significantly bigger and different than the preceding two. I'll pause. Steve, what? I talk too much.
Thanks, Jim. Representative Blanksma, I mean, I understand what you're looking for. It's a little bit more complicated than just saying that when the COVID census goes from 10% to 12%, we open our physical therapy gym, which has the capacity for 3 beds, which, by the way, it does, in one of our floors. And when we go from 12% to 15%, we open a 17-bed unit that we have available. And when we go from 15 to 20%, we make the following changes in terms of inpatient COVID volume. And the reason it's a little more complicated than that is that while we're making those changes, we're also simultaneously deciding which, quote, elective surgery should not happen. And obviously, a facelift would be something that wouldn't happen. Knee replacement, to Jim's point, would be something that we'd like to be able to happen. And a tumor in a patient with, adenocarcinoma sure as hell better come out as quickly as we can get it. But I will tell you, back in July for St. Alphonsus, when we hit 10% of our inpatient volume being filled with COVID, we were still able to continue virtually all ordinary medical care. When we hit 15%, that's the point at which we discontinued the things that we're talking about, like facelifts and other kinds of truly elective surgeries, which frankly we're doing very, very low right now because patients are not interested in having those things done in the middle of a pandemic, safe or not. So circumstances have frankly changed since July. And then the other thing that's changed is our total census, patients coming to us with infectious disease, traumatic disease, and other kinds of conditions where there's no question they need to be in a hospital. Those numbers have increased. So COVID is now built upon, in our system, a SARMAC inpatient census that has gone up of necessity by a significant percentage. So while we have surge plans, they're multi-component, and it's difficult to share that information in any context that would be valuable beyond what we're already publicly reporting, which is pretty extensive. We're giving you our inpatient volume, our COVID volume, discharges, test positivity rates, and a variety of other things, in the hope that it's just factual information and that transparency is understood and respected. And we then depend upon leaders like yourself and also the media to provide messaging around what that all means. So the last thing I'll say is, where are we at St. Alphonsus right now is our total COVID volume inpatient is approximately 10% and growing. It's built upon a total inpatient census that is already near what we call staffed volume, our total ability to staff beds using regular ratios of nurses and medical assistants and pharmacists and so forth for patients. And part of the reason for that is the fact that we are now experiencing more staff outages than we did previously. And we've also had staff who don't want to do this anymore. And that's part of the tragedy of this, is people are worn out and they're deciding to take care of themselves, which is a very necessary and important thing to do, but not to take care of patients. So I hope that helps. If it doesn't, then we should spend some time offline, and I'd be happy to walk with you personally through the way that we make some of these decisions and the complexity thereof.
Madam Chair, this is Diana.
Yes, Diana, go ahead.
So this is either doctor can answer, but I want to sort of harken back to June, when we clearly had a surge that.
Diana, this is Betty Ann. We're getting a lot of feedback and static from you right again.
Okay, I'll go off and come back.
Okay, thank you.
Madam Chair, this is Ted Epperly. Yeah, I'll
Yes,
jump in
go
while
ahead.
Diana, yeah. Thank you to both of you. Really appreciate the comments and the concerns. Couldn't agree more that what we need to focus on is what we can control, which is face masking and distancing. The rest of that is one of those things that will happen if we can't get in front of this better. That said, I'm struck by the fact that the third spike of this surge is so significant in the latter part of October. We've got a long, long way to go between here and March, April, May, a long way to go with significant amount of issues happening. It is a perfect storm. We've got viral season upon us with colds and influenza. We've got cold weather driving people in. We've got a lot of things that will be like gasoline on this fire. So to both of you, knowing that it's October 27th and that we've got a long winter in front of us with COVID and other factors that make this complicated, to the best of your ability, help us now on October 27th in regards to the prognostication of what this might start to look like. I recognize we're not in the business of panicking people, but we're in the business of educating people. And it'll be really important that you do your best right now with us and the community in regards to what are we looking at in December, January, February, March, to the best of your abilities.
Steve,
Let me
you
go
wanna-
first.
Okay.
Yeah,
Yes.
you looked a little slow,
Go ahead,
Jim, so I
Dr.
figured I'd go
Members.
first. It's obviously difficult to prognosticate months ahead, but I'll tell you what I think we're looking at weeks to a couple of months ahead. So at the current trend, current spread rate and transformation of hospitalizations, which Ted, I think you talked about earlier, we would expect a doubling of the total inpatient COVID volume in approximately two weeks. Maybe it'll be a little bit slower than that. Maybe it'll be 3 to 4 weeks. But if I were to make my best estimate right now, a doubling of the total inpatient COVID volume in approximately 2 weeks' time, then a tripling within a month to 2 months. And with that continued growth rate, then in my health system, in 2 to 4 weeks' time, we would be beginning our ramp down process and discontinuing those things that we already talked about discontinuing, and simultaneously continuing to open other space for COVID patients. And the one thing that I think we're going to be struggling tremendously with is inadequate staffing. So in approximately a month or so, we would then have to go to alternate team-based care arrangements. And what that means is that our doctors, which we can't, they don't come from heaven, they don't rain down from the sky, they have to be licensed expert providers, and getting them when everybody else wants them, for the few that are available that aren't already working or not working in the hospital, and getting them out of our clinics to work in the hospital. That is going to be a struggle. So we need to then expand their ability to take care of more patients, which means that we use other kinds of providers who would not normally be doing that care. A good example would be using a nurse anesthetist in the intensive care unit to care for patients. And the same thing with nursing teams, where we would use an augmentation of team-based care to provide for the care of more patients with fewer staff. Connected with that fewer staff then is how many of our staff will be on quarantine and leave, and also needing to take care of their families and themselves. And the answer to that is some unknown percentage, but it's greater than current quarantines and sick outs and so forth that we're seeing currently. So when does that become a tremendous struggle? A month from now. And when does it become crisis conditions, meaning the kind of severe rationing of care that Dr. Souza shared would be some period after that, based on current predictive modeling. The last thing that I'll say is that's with continued steady growth of this virus. What could also happen is exponential growth of this virus, because if one person infects two people, right now it's about one person infects 1.3 people, something along those lines. But if the infectious rate of this virus continues to grow, then we'll see exponential growth. And my predictions will be considered quite conservative, and we'll be looking at far more severe scenarios. And we look at this every day. Dr. Souza and I, and we have a collaborative of healthcare leaders across the state that share information to make sure that we are using the best estimates and fully prepared. For example, our primary care doctors are kind of the canary in the coal mine for us. They see the sick patients in larger numbers before we do. And if some of them were on this call, they would tell you the numbers that they're seeing and the growth that they're seeing. So I hope that answers your question.
Madam Chair, this is Representative Blanksma.
Yes, Megan, go ahead.
Can I hate to interrupt, but can I just get a quick definitional explanation just so that we're fully understand what you're saying? When you're saying 2 or 3 to 4 weeks to double inpatient COVID, are you talking ER visits, ED visits, or are you talking inpatient COVID, perhaps in for a different issue, not necessarily severe COVID? These are the kind of definitional things people have concerns about. So if you can explain to me what you mean by that.
Yeah, so when I say a doubling of inpatient COVID admissions, that would be where COVID is the primary diagnosis and the cause of whatever the patient's dysfunction is, respiratory, cardiac, neurologic, vascular, that COVID is the primary cause of that, and the treatment is geared towards the symptomatic treatment of those conditions combined with treatment of COVID. And ER visits in our system generally track directly with inpatient hospitalizations. The more ER visits, the more in a sort of linear way, but obviously a much smaller number actually require hospitalization. So I hope that answers your question. And Jim, maybe you can speak to your numbers as well.
Yeah. Thank you. Yeah, our modeling probably puts us in the ballpark of 140 COVID inpatients, just like Dr. Nemerson just described, long about 2 weeks from now, 2 to 3 weeks from now. That's what our short-term forecasting looks at. The range is kind of 120 to 160 at this moment in time. I think what we could expect as a result of that, I think it's more probable than not that we would need to create increased ICU capacity sometime after that. We're already doing creative things with staffing. I was sharing with Dr. Nemerson recently that because of what happened in Magic Valley and the fact that we had sick providers out as well, who had also acquired it in the community, we had to use our bench here in the Treasure Valley through telehealth to support those teams there. So we'd be doing more of that for sure. Dr. Nemerson talked about more creative care teams. We're also down that pathway of getting ready to, we've got them designed. If these numbers play out, we'd and we have to upstaff a new unit. We'll have to deploy those. And then, of course, with all of this would come these delays in surgeries and cardiac caths and those other procedures. You know, the worst case scenario is all those things fail, and then we're in crisis standards. Again, I really don't think, I'm really hoping we don't get there, and I don't think we will get there. I continue to be optimistic that people are going to rally to this call. This is not one time or two times. This is now the third time. I don't think we've been crying wolf. I really don't. But we're just sharing right now the terrible cost we'll pay if we continue to let this happen. And the other reason I'm optimistic is I do think I already referenced all the needless suffering and death. These numbers, as they play out, increasingly, we're going to find ourselves at the point where literally all of us either know somebody who got really sick from this and fortunately got better, but suffered, or knows somebody who unfortunately died from this, or knows somebody who had this thing. Like, I know several of these people now who their symptoms are going on and on and on. I think as that moves it from the sort of non-real to the real, I just have to be optimistic. We're going to take action to stop this. I would share Dr. Nemerson's commitment, you know, to give more of my time to tell these stories, to explain, to make it more clear. Because if we wait for every human being to be able to make that connection, to make it real, well, we're just going to hurt a lot of people on the way. And we simply don't need to let that happen. We know how to control this. Hope I answered your question, Dr. Epperly.
Madam Chair, can you hear me now?
Yes, that's better. Thank you.
Okay. So, you know, clearly over the summer we had in Ada County, or really in the Treasure Valley, that I guess it was second wave, maybe not second spike, but part of my frustration at the time is that I really believe we did the right thing. We made the hard choices, not fun choices, but we did the right thing to preserve our healthcare capacity. My frustration being that we're one health district, and as you know, especially, well, really for both systems, we're very interconnected in this valley. And really since that time, you know, we have people going to and from, and there's different regulations. The governor has expressed his desire to continue trying for more localized approaches, and I understand that. Obviously, he's moved us back to stage 3 from the state perspective, and I'm hopeful that will help. I guess what I'm trying to understand or think through is, even if this board was inclined just to move forward with things in Ada County, knowing we're the population center, would that even be enough to preserve healthcare capacity? So that's question number one. The second part for me is that I have major heartache about even considering that, knowing that it would hurt our businesses, while we have other counties with major spikes who won't even consider a mask mandate. So answer question number one about whether it would even be enough.
All right, Steve, I'm still off mute, so I'll take this one first. I'm concerned it would not be. You know, so you pointed out in the data session early on that coming out of Ada County, for example, we're not seeing more ICU admissions yet. But I shared with you that we're seeing more ICU admissions. 'That's because they're not all coming from Ada County. Some are coming from Canyon County, some are coming from south central part of Idaho. So the answer that I would give is no, I don't think that will be enough. I tried to make the point that we can't think about this like we're all in separate fish bowls. We're all in one big aquarium together. We really are. We just like we share the air, we share this environment. What was the second question, Diana?
Well, it's less a question and more of a comment, which is that I think this board has acted appropriately. I think we made those hard choices that some other health boards haven't been as inclined to do in service of preserving that healthcare capacity. But I'm going to be fighting hard to make sure there's more consistency, because it's unfair to burden or further restrict our businesses if it's not being done elsewhere. So that's just, we're not being asked to do that today, but I'll just kind of put that line out there.
So if I could add, I would suggest that no, it won't be sufficient to completely turn around the continued COVID growth, but it will contribute to decreasing the rate of growth, which is more than helpful. It's necessary. But the other thing is, I believe that the public health department and Central District Health, you guys, have an obligation to protect the citizens of this region. And part of protecting them is to prevent them from acquiring COVID themselves. So if you think about it from that perspective, and I understand the economic implications well and the struggle with that and how unfair it is for this district to be making a decision alone when others aren't willing to make that courageous decision. However, I would suggest that the way to prevent transmission of virus from one person to another is for both to have masks. And the way to prevent the transmission of virus from other people to an individual is anybody that surrounds that individual at whatever distance needs to be have a face cover on. And so the virus is not going to decide that because somebody comes from Ada County, they're not going to be infected. It's not that kind of process. And so I would encourage you to be courageous, because you are protecting the people in this community. And there is more than great value in that. There is a sacred obligation to do so. That would be my thought.
And I just want to clarify, we're going to keep looking at this week by week, but this really is where that regional approach or statewide approach is going to be so necessary, because I have a hard time stomaching closing down whole categories of businesses, again, when right next door there's not even a mask mandate. That is a really hard pill for me to swallow, for our residents, and also less effective, frankly, because we know that people are headed right over the Canada Road. So I know you guys have been advocating, looking at things more regionally, more statewide. I just want to be really transparent about where my heartache is. And obviously I'll make those decisions as we come to them, but it's something we have to keep advocating for.
Yeah, and I don't think we've talked about this today, Jim, but we did release a letter as physician leaders across this region. And in that letter, we gave very specific recommendations about when and where different communities should be looking to ramp down social activity, to discontinue different kinds of interactions, different crowd sizes, and to even consider whether or not in-person education is warranted.
Chair, this is El.
Yes, El, go ahead.
I don't know how to start this or begin this, but one of the things that I've noticed from the beginning, clear back to March, was there was not much concern by the younger crowd in our society about, well, I might get sick and I might, but I'm going to recover, I'm going to be okay. But we know now that it's really hard on 60, 70, and 80-year-old folks should we be considering something different as far as from the health districts for age groups, or do you think that would just be a waste of time?
I think my take on that is I'd love to see a more organized and coordinated communication and engagement blitz of young people that's technology enabled. Our health system isn't going to do that. I'm not sure that that's a health district's role, but I believe that, speaking in very broad general terms, this is a generation of young people that appears to be in tune to their fellow human beings. And I feel like we just haven't conveyed the message enough to that group. And on the other side, they're consuming a daily diet of social media fueled malarkey. That this is either a hoax or a nothing burger. And it is neither one of those things. So that's my thinking on the young people, is not dropping different requirements on them, but engaging them in a different way. But that would take, some effort and getting organized. Those are my thoughts on young people.
If I could do a follow-up, Madam Chair, last week we kind of put out some guidelines as far as nursing home long-term care centers, and I'm almost regretting that we did that, because now we've exposed them more. Although maybe they can make it work, maybe not. That's what I'm trying to get to, is how can we get this out to the middle-aged and the younger folks in our society, that this is more serious than you're learning about on social media. Just a few days ago, we had another county next to us that declared that they were mask free and they would never pass a mask mandate. And it's like, I don't know. I guess you can't change the stupidity model in folks, but this is so frustrating. It's just like nobody seems to be taking it serious. And maybe the hospitals could do more to help us PR this with the younger folks. I don't know how to do that myself, and I guess I'm asking for help.
Yeah, I will say that we have speakers, physicians who are in the war against COVID that are available. We make public service announcements. I think most of you have probably seen them. We participate in all kinds of news conferences, including one this morning. And we've got regular participation in radio shows. So I think we're doing absolutely the best we can, but if there are other ideas, we certainly have people who are experts that are willing to find their voice and help out.
Yeah, we do have to admit that the chain of logic in explaining this is a little more complex, right? Because at the individual level, those young people may not, they'll probably do just fine. But if they become the nidus of a super spreader event, and this is well proven now, like as if we needed this documented. There was an article published in the peer-reviewed literature last week that did genetic fingerprinting of an outbreak of COVID, demonstrating that, a group of young people that created a stochastic, super spreader event, that several deaths in some elderly folks were genetically fingerprinted to that same virus outbreak. So it's that chain of causation it's hard to explain to people. It's a lot easier to explain if I get this, something bad's going to happen to me. Well, the story here is if we all don't contain this, something bad could happen to any one of us because of delays in care that we need or someone we love needs. It's inherently more complicated.
So I just want to jump in because I got a text message, and in real time we have a physician staffing concern that I'm going to have to address in about 5 minutes, and certainly related to the things that we've been talking about here. So it's an opportune time to mention that. Hopefully I've shared the data that you're looking for, the current situation that we have going on in our health system, given some context that really links to what Dr. Souza and Dr. Epperly and others have been sharing here as well. But I'd like to invite any other questions about St. Alphonsus before I have to drop off.
Well, Dr. Nemerson, this is Chairman Nettleton. I'm not hearing any more questions or discussion directed to you, and I just want to thank you on behalf of the board for your input tonight. It's been very helpful, and we're all in this together, and hopefully we can move forward in a proactive manner. So thank you so much.
Well, thank you, and I'll hang on for a few more minutes. I've got a couple till I have to zip over to the other. So thanks so much, and again, I appreciate all your hard work in allowing me to participate, to share what we know.
I'd echo Steve's comments, and I can stick around for a little while longer. Just let us know when we need to exit.
Madam Chair, this is
Yes, Al, go ahead.
I'm just wondering if there's any way, and this sounds really inhumane, and I don't mean it to be, but I'm a cattleman, so I see this kind of stuff with cattle all the time. But if we could get more stories about what happens with someone in younger or middle age or younger that has had the disease and what they've had to go through, not saying names or places or where they live, but get those kind of stories out, maybe that would be one of the things that would click with the younger folks, that, hey, this can happen to me. Because right now, we just learned last week about 79% are asymptomatic, and they're going, well, what's the big deal? Well, they don't realize the big deal is when they go home and see grandma and grandpa. That's the big deal. And we've got to figure out a way to communicate that with these younger folks. I don't know how to do it.
Madam Chair, this is Ted Epperly. I'd like to make a comment here and maybe another question to our guests before they leave.
Yes, Ted.
So I served in the United States military for 21 years. I was in the Gulf War, and I triaged life and death situations. I know some of the decisions I made caused the deaths of young men, and it's something we don't want to have happen. I can tell you that the trajectory of the course we're on will worsen. There is no doubt about that. You've heard from both Dr. Nemerson and Dr. Souza about the accelerated timeline of this, even faster than we thought. And we've got a long way to go. This will get a lot worse. When we read about New York City and New Jersey and the depths of what they were in, we could very much look like this. So I know I'm speaking to the choir here on the board, and this is more directed at the public. What we can do, both of these fine physicians have mentioned, and that is our own personal accountability for wearing face masks and distancing. As Dr. Souza said, it's face and space. It is the single antidote that we all can bring to the equation to slow this down. I've said before, and I believe this, we've not gotten sick enough yet to take this as seriously as it is. This is not a hoax. This is a reality that we can start to change. So what I would just leave with the public, and both for Jim and Steve potentially to comment on, is that the only thing under each of our controls that we can do to make this better is pay serious attention to all the public health measures we can do around appropriate face masking, social distancing, space requirements. That is the way we can do this. And we need to amplify this message, because without it, we will get into this situation. It's already knocking at the door. If you've not listened to this tonight and heard that from these two gentlemen in their hospitals in October versus December, January, February, and March, you need to hear this. And the community must take this seriously. That's what this is all about. I'll stop with that.
And Ted, I'll just say that was extremely well said. And I want to offer this same audience encouragement to say that we know these measures work, and we also know that it can turn the curve around within a matter of weeks, really within a matter of 2 weeks. So, I hope we can get some traction here. I hope we can get some compliance with the things that people already know what they need to do. It can make a big difference. And thank you again for allowing me to participate.
Ted, that was really eloquently stated. I'd only add to it that, like inside of our health system, we got to experience the wisdom of what you just said, because in the first peak that we unfortunately got to experience there in Blaine County, where we had to shut an entire hospital, we experienced a whole bunch of transmission, to our own people, because we didn't understand it. Like the world didn't understand it at that point. Since then, and since hardwiring those very simple practices, I mean, if anybody who's listening has been in a hospital, they're filled with people. They're indoors, and we're not transmitting the virus because we universally wear face coverings, because we universally watch our distance, and it's the very rare breaks in that lead to the transmission events. We can take that out into the public square and be successful with it. We can have safe economy and preserve healthcare capacity. And my last comment would be that I just want to double down on saying that, like everybody who cares about healthcare, the last thing I want is for huge swaths of our economy to be shut down, to exacerbate the economic damage, to worsen the depression, the substance abuse, the child abuse. I don't want any of that. That's not consistent with the healthcare goals that we all seek. And the antidote is pretty painless.
Any further discussion for Dr. Souza and Dr. Nemerson? Well, hearing none, gentlemen, I just want to convey our gratitude to you for your input tonight and the importance for our populace. Out of our district, of course, we have only critical care or critical access hospitals, so we are definitely, there's only one place for us to go. And we certainly appreciate your forethought and planning to accommodate those of us who have no choice. And with that being said, I will just once again thank you and look forward to hopefully our public and especially our young people being more cognizant of the simple things that they can do to protect all of us. So thank you so much.
You're very welcome. Thank you for your hard work and your great questions tonight and your leadership. I'll sign out. Thank you.
Okay, thank you so much. Thank you so much. And Dr. Nemerson is already off, I trust.
Yeah, I think he is.
Okay. Thank you, Dr. Souza. Good evening. Okay, moving on with our agenda. Item number 6 is a discussion and vote regarding potential actions to protect the life, health, and safety within the district as to the COVID-19 pandemic, to include potential amendments to current public health orders and additional orders for other counties within Public Health District 4. So the floor is open for discussion.
Betty Ann, this is Ted.
Yes, Ted, go ahead.
Maybe, boy, wow. Maybe the best way to start this discussion, and I'm not sure it needs to be an overly long one, because we've hit on the things that we can control and we need to continue to focus on. That's the public, the simplicity of public health. My real anxiety with all of this is that we know that where the breakdown is happening, because we've got data, we've made policies, we've educated. Where the breakdown is happening is with enforcement. Enforcement, to me, is a personal choice. It's our own enforcement of our own behaviors. But sadly, that just doesn't play well across all of our population. We've got equal numbers of folks that are not enforcing this, as are. And so what I'd like to ask Russ, you've heard all the discussion tonight. You've lived this. You're as deep into all of this as anybody. Hearing this tonight, knowing that public health is the only thing we can leverage at this point, but doing it better, what would be your recommendations to us at this juncture about next steps forward?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Well, I think a couple of things. I really want to continue to step up our education efforts, and that's something like the hospitals have done. We work closely with them. We have our own social media campaigns, our frequent interaction with the media. So that's probably number one. That's a real challenge here, and I think, as was described and Commissioner Hasbrook described, I do feel like it's going to take getting to that point where somebody who had it, know somebody who got really sick, and possibly know somebody who died. Personally, we have one of our coworkers here who lost her mother early on in the pandemic from COVID. That's the first person that I knew who died from this infection. And now that's continued. I know plenty of people who have become sick, some of our coworkers here who have become sick. So I wish I had that silver bullet or that magic solution, but I don't. I do think that our orders are the appropriate step. I don't believe that people across the board ignore them. I live here in Ada County. I live in Boise, and I think they work. Now, is it every store and every person? The answer is no. But I can tell you from traveling outside of this county, I think we're in a much better position than many other counties are. And I hear that from my staff who actually live in other counties outside of Public Health District 4. I would recommend that the board, at this point, seriously consider a mask mandate for Elmore County based on the case counts that we're seeing there. And if not for the entire county, certainly the two populated communities, which would be the city of Glens Ferry and the city of Mountain Home. And the reason I bring that up, we talk about this at almost every meeting, the effectiveness of face coverings and physical distancing. That's not shutting down a business. That's not sending kids home to learn virtually. That's a very simple step that people can take when they're out in public places, interacting with people that are not part of their immediate circle, immediate family members. You know, we did that for Valley County at Commissioner Hashbrook and his fellow commissioners' request. And look at the data. I mean, Kim can describe that. You can look at our website. It appears to be quite effective up there. And they had the influx of, the travel back and forth from people from Ada County and Canyon County and other areas. And I think that's probably slowed with the change of season. But that's something that, if you're asking for a recommendation, I think we need to continue to ramp up our education efforts. And from a order perspective, I think it allows businesses, if we do a mask mandate, face covering mandate, it allows the business community to take those steps, and it levels the playing field. Again, not unanimously, but it levels the playing field. And I want to point out, when people put effort into it, it works. Like you all approved Spectra Productions opportunity to move forward with the home show. We sent staff down there to ensure they were complying with the plan. I'll tell you, they did an amazing job. And he did that because David Beal, who petitioned the board, he did that because he wanted to continue to have those types of events, which from my perspective, he should. So, there's no, again, simple solutions to this, but I do think face coverings, from where I sit, is the absolute least restrictive, most effective means that we can put forward to help slow the spread of the virus. And for sure, based on the data that we're seeing today, Elmore County would be the location, that geographical area that I would recommend that the board consider.
Madam Chair, this is Diana.
Yes, Diana, go ahead.
Russ, have you already had, or based on the data, are you planning to have conversations with the mayors or county commissioners in Elmore County?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
I know Chairman Nettleton and I believe Representative Blanksma have already had those conversations and have shared with me the response. And I will certainly move forward with having those conversations myself with the mayors and the commissioners, but I haven't done that yet.
Chair Zelt.
Yes, Zelt, go ahead.
Russ, I know at one time we were at a situation where we limited groups to like 25 or 10 or some magical number. Do we need to start considering that as well?
So, to do that more broadly, we have that in place for Ada County, 10 or fewer social gatherings, and basically up to 49 for all other gatherings. And, I don't think that's a bad step to take. I do think, where we're seeing a lot of the spread happening are small gatherings, social gatherings, outside of family members. They bring it back to the family, spread it through the family. So, the governor has just issued orders where they're limiting the size of gatherings, but Ada County is basically the same or more strict. As I described, there's a social gathering aspect to it. So, that's another option. I think at the end of the day, if people would wear face coverings when they're around people other than their immediate family or their household, I think we would see a slowing of the virus activity. And again, I would say that as a first step, and let's see what happens. Obviously, if things get as are predicted by our health systems, get that bad over the next few weeks, and I think we'll have to take more serious steps. Again, I will be making those recommendations to the board, but for right now, what I would recommend the board consider would be a face covering requirement for Elmore County based on our case rate being equivalent to what we're seeing in Ada County.
Madam Chair, it's Diana.
Yes,
Russ,
Diana.
would you like us to consider that tonight, or would you like the opportunity to have those conversations with mayors I guess I say that because I think we've done well when we've sort of socialized some concepts before immediately doing something. So is that, what are you looking for here?
Madam Chair, Russ,
Yes, Russ, go ahead.
I would recommend that we put an order for consideration together for the November 4th meeting. And in the meantime, I will have those conversations and be able to share that back to the board as far as what kind of response we might get. I don't think, given their relatively small population, it's not Ada County. I don't think things are going to necessarily get out of control in a week, but I do think it needs to be clearly on your radar, and I will have the conversations and report back.
Madam Chair, this again.
Yes, Megan, I was going to ask you to weigh in, please. Go ahead.
Sure. And if you want to weigh in as the other county representative, I mean, I don't know how you feel about that since you're chairing the meeting. But I will say this. I want you to all look deep down inside and think about how you would feel as commissioners if people from other counties started putting mandates on you without discussion and without consent. And I think that right now, if you decide to consider this mandate, you're going to do it without the support of this Elmore County representative, because it is not, there's not been the discussion with other citizen representatives in the county. And we're talking about, they were given the heads up at the end of the next week, or the end of last week, beginning of this week, it officially went to a red category, and nobody's had a chance to evaluate why that happens. And I would also point out that the Valley County map order was at the request of the commissioners. And this is not necessarily without the knowledge of the commissioners, but at this point, I feel fairly confident that they in no way have consented and don't have all of the information to even be willing to make that consent. So I would tread carefully here. And I would think that probably Russ having some more conversations would be useful before any decision was made here.
Well, this is Chairman Nettleton, and I actually echo that. Megan and I have both spoken with, I have spoke personally with the mayor of the city of Glints Ferry on a number of occasions, and they indicated absolutely no consideration for a face mask mandate or a city ordinance to do that. I think that Megan recently had a conversation with one of the city councilmen and maybe the mayor of Mountain Home, I believe. Megan, is that correct? And they also indicated a very soft rollout. I think we'll get better cooperation if we establish some communication before we try to do this. So, my take.
Madam Chair, this is El.
Yes, El.
You know, I agree with you both on this. This is something that the health district's going to have to go back and talk to the mayors and talk to the commissioners and just explain the situation to them. At least that way we know at the end of the day that we did our part as much as we could, and it was up to them to make that call.
Madam Chair, this is Ted Epperle.
Yes, Ted.
Yeah, I would agree as well. All of us want to be talked with and given choices and options. I think it's really clear, though, from tonight's meeting that we've got to ramp up our game plan and our operational plan. So I'm going to suggest several things for consideration, Russ, to bring back to us next time. And I want to start with four items here. But I want to make one comment, and the more I've been a part of all of us trying to help the community the best we know how to do with COVID-19, the more I've become really aware that we've got to keep our economy going. We've got to keep living. And so this really does get into the realm of we've got to learn to live with this and do our best with this. But we've got to all, again, step up our own personal games with this as well. So, Russ, if I can, I'd like for you and the staff to contemplate these next 4 items to come back to our meeting on 4 November with. First is the due diligence of talking with the folks of Mountain Home and Glens Ferry, Elmore County, as was discussed, so that we can all be informed of next steps forward. Agree totally that that's the best way, is to help educate them to the seriousness of the problem, and to have the conversations. And perhaps you can bring back to us the results of that conversation, and then potentially a recommendation on next steps around face masking, as you said. The second of 4 is we do have to ramp up our education. We've got to try to get the message out more clearly about the serious nature of this. And I recognize that, again, if you don't have someone that you know that's gotten sick or have died, this almost feels like, why is everybody overreacting? I'm telling you, it's not an overreaction. And this is a serious issue, and we've got to all approach it that way. So, Russ, if you could come back with thoughts around what the ramped up educational plan could look like. The third thing, Russ, is I'd like for you to potentially have you and your staff, perhaps with the county commissioners as well, some conversations about enforcement. What does enforcement look like? Now, I made a statement earlier that the real key to enforcement is ourselves, what we decide to do as individuals. We all need to be accountable for this and enforce ourselves and our loved ones better. But I really would like to hear, and perhaps we have the chief of police or the Ada County sheriff on as a guest next time, so that we can start to talk about what does that look like. If we can't individually approach the enforcement of this, is there something in the community that we can do to help with this? Because we know if we can get on in front of slowing this down, we can change the course of this. That's the amazing thing to me. This is prevention. The last
Madam
thing,
Chairman, just point of clarification, please. Is this a motion that that the board is directing the director to do these things, or is this a request of Dr. Epperly as a board member? I'd just like clarity on that.
yeah, I'm making a recommendation to Russ from my perspective, on 4 items that will help ramp up our operational game plan. That's what this is. So I'm getting to number 4 now.
So you're making a personal request as a board member of what you'd like to see from Russ.
Yes, that's what I'm doing. The 4th thing, Russ, is we have holidays coming up. We have Thanksgiving and Christmas. It's a time where we're going to have a lot of infection in the community. I am absolutely not against any mandates around Thanksgiving, Christmas, or holidays. But what I would like for you to consider with you and your staff is what would be some recommendations to the community of how all of us can best deal with the holidays in regards to the personal nature of this and how we can try to keep as many people safe as possible. So just as a quick summary, number 1, the discussions and the thoughts around the mask mandate in Elmore County with the appropriate conversations and your recommendations. Number 2, what the ramped up educational activities would look like so that we can get the message more clearly into the community. Number 3, what enforcement might look like at a larger level than just individual enforcement. I wish we could control it there. Maybe we do, maybe we don't. So the consideration of potentially having thoughts about that at our next meeting. And then lastly, potential recommendations that we could work up for the public and the communities that we serve in regards to the holidays. So with that, I'll stop. Thank you.
Madam Chairwoman,
Yes, Megan, go ahead.
it's Representative Blanksma, a motion to adjourn.
Okay, and there has been a motion to adjourn. Is there a second?
Second, this is Diana.
I'm sorry, Diana, was that a second? You're breaking up
Yes.
again. Okay. Okay. The motion has been made and seconded for adjournment tonight. Is there any further discussion before I call for a vote?
Madam Chair, this is El. Did we get through all of our agenda?
Yes, we did.
Okay, thank you.
Okay. Starting with the vote for adjournment, Valley County,
Commissioner Hasbrook, aye.
Elmore County,
Representative Blanksma, aye.
Boise County,
Commissioner Sturm, aye.
Ada County,
Jane Young, aye.
Ted Epperly, aye.
Diane, are you there?
Commissioner Laciando, aye.
Okay, thank you. Okay, folks, the motion for adjournment unanimously has passed, and I thank everybody for their participation tonight, particularly the public who, I hope there's a lot of public listening in tonight to Dr. Nemerson and Dr. Seuss's presentations. So our next meeting, as previously announced, will be November 4th at 8 o'clock. So thank you for all of your interest, and good evening.
Dodgers are losing, you guys.